wonderful VP of Product Content, and her name is Jennifer Bishop. Jen, hand it over to you. I can hear you.
All right,
sorry,
perfect.
I should have made that more clear.
Yeah, no, great. All right, welcome everybody. We are going to talk about the HIM focused codes, which generally I take to mean the 1000 through the 6999. We're also going to cover the Category III codes that would normally be assigned in the HIM department. So my usual disclaimer here that we're current right now, but I can't even believe how much and how fast things are changing this year because of everything. So we will keep everything updated in the VitalWare product, and that includes our documents that give you an overview of all of these changes. So I'm going to start with my second disclaimer, because if you listened to me yesterday, this is the biggest question that I get, which is, wait a minute, why don't your numbers that I'm seeing here match the numbers that I'm seeing from the AMA? And that is because their numbers by design are changes from January 1st, 2020 that were in the book to the changes that are published in the 2021 book. So they basically cover a year's worth of changes when they are talking about changes. We are focusing on the January 1 changes because we produce quarterly changes to keep you apprised in a more timely manner than what the book can do, because it's published. We can't publish it all the time. So don't expect my numbers here to necessarily match the numbers that you see in your addendum B, or that you may have seen in other sources from the AMA. Also, I don't include, if it was only a change to the short or medium description, I'm not going to include that as a significant change here. Just be aware of that as well. All right, so let's start with changes to the surgery section. So again, that's the 1000 to the 6999 section. And my first real slide here is breaking that down for you, just so you can see where the changes occurred. We don't have a ton of changes here, particularly with what we normally have, but we do have a number of revisions to the integumentary section, coupled to the musculoskeletal and on down. So it's actually fairly nice this year. And of course, you are going to get these slides, so you'll be able to take a look at that in detail at your leisure. All right, so let's jump right into the integumentary section, and this is where we have the majority of the changes. So we had a couple of codes that were deleted this year, specifically the mammoplasty augmentation without a prosthetic implant. And the AMA is recommending suggested replacements of 15771 or 2, which is the autologous fat grafting. Basically, they determined that if breast augmentation is being done and an implant isn't being used, it has to be fat. And so it's more appropriate to look at the grafting of fat harvested by liposuction. They've also deleted 19366, which was basically a kind of catch-all of breast reconstruction that wasn't described by another code in the code set. And they kind of decided that really isn't necessary, that they feel that they've pretty well delineated with specific codes all of the appropriate breast reconstruction methods that are currently in use. If you disagree with that and feel like they've missed a code, you would have to go to the unlisted procedure code. All right, a lot of writing on this. We had a lot of description revisions. I think there were 17 if you go back over there. They're not as onerous as they appear, so I kind of grouped them here just so we could see what they were. Basically, significantly, they took the word prosthesis out and replaced it with the word implant, just, an update to more current terminology and to be consistent with other sections of the book. They also took the words mammoplasty and mammary and basically just replaced that with breast. Again, just a little you know, less onerous terminology, updating things. We had a few codes that had clarifying instructions that were added to the base description, which I'm always grateful for. Although I kind of wish some of these got really big. I kind of wish they would just publish guidelines and not necessarily add everything to the code. But whatever, we're getting guidance. That's a good thing. We have a few codes that were just reworded for consistency, and a few codes who didn't change appreciably. They were just basically made parent codes. So changing from a comma to a semicolon, basically. So now I just wanted you, again, hopefully this helps everybody when they get the presentation and they're looking through, just to be able to quickly see, okay, in 2020, they deleted prosthesis, they inserted implant. So this is just a through of the differences in every code that was actually changed. You can see some of them look like they were changed quite a bit. But this is really just kind of clarifying instructions for 19330. I like that they did this. It basically used to just say removal of mammary implant material. It's now qualified that it needs to be ruptured breast and that it includes all of the implant contents. 19340, again, just, I like this. Instead of saying just immediate insertion, it now clarifies that this is to be used for an implant that's done on the same day as a mastectomy. And we're going to go over, there's some guidelines in a second to help you a little bit more with some of these changes. And now instead of delayed, it actually says insertion or replacement on a day separate from mastectomy. Tissue expander placement in breast reconstruction has been changed. This was just a little nebulous, I think, as to, you know, we're just rewording and reclarifying. And like I said, there's going to be a lot of instructions that we're going to go over here in a second. We've got some parent code stuff here. They've redefined a little bit just to give you some help. Instead of just breast reconstruction with free flap, they're actually clarifying what types of flaps would be considered a free flap. I'll take that every time. It's kind of nice to get that additional clarification. And then we've got just some rewording. Instead of the single pedicle being down here, we've kind of put it up here. Not so big of a deal. And because we had the single pedicle flap, we now have a bipedicle flap instead of the word double pedicle, I guess, whatever. Sometimes I feel like they just make changes for the sake of making changes, but that's the only real difference there. And then you notice here are our new paragraph code descriptions. Like I said, they're trying to help here. Instead of just saying revision of reconstructed breast, we now have exactly what that would mean, being significant removal of tissue, readvancement, reinset. And they did add guidelines to help with that we're going to go over in a second in the next couple of slides. So apparently there was some confusion in the breast section that has led to them doing some major revisions and clarifications of this section. So here's a taste of the new guidelines that we got added in conjunction with that. So we added a guideline for 11970, the replacement of the tissue expander with permanent implant. That's going to include any minor revisions that you do to the breast capsule in basically getting out the tissue expander. If there is more extensive revision required than what is normally done, you can report that with another code of 19370. Now, they didn't totally clarify what a more extensive revision is, and that is a lot of times our challenge as coders, right? Is what is normal revision. So I would expect, hopefully, that there will be some more guidance forthcoming on that. There have been notes added to direct the users to 11970 and 11971. If tissue is expanded, if tissue expander is removed, whether or not insertion of breast implant is done. 19342 also has a new note on it to instruct coders that includes removal of the breast implant. And 19342 is not to be used for replacement of tissue expander with the breast implant. For that, you're going to go back to this 11970. All right, some more guidelines. Placement of the breast implant or tissue expander can be separately reported when it's done in conjunction with flap reconstruction. And I've listed out the codes there as the AMA has them. Flap reconstructions can be done at the time of mastectomy or after mastectomy. And they include harvesting of the graft, closure of the site, and insetting and shaping the flap. Just again, to clarify what shouldn't be reported separately. All of those things are included, so don't try and find additional codes and add them for the flap reconstructions. All right, on we continue with all of these guys. If you look at your book, there's just a whole sea of green in this section because they added so much to it. Okay, 19370 is not to be reported with 19328. Those are included, and I have to assume that when I see these kinds of guidelines, it was because this stuff was being done or they anticipate it being done due to some of these changes. 19371 is also not to be reported with 19328 or 19330. Anybody feel like I'm just throwing codes at them? I tried to make sure that I had all of the code descriptions out in one place or another, but this gets really wordy. All right, and 19380, the revision of the reconstructed breast, is going to include revision to the flap position, removal of a piece of the flap, reshaping the flap, and revising scars. Okay? If you insert a new implant at the same time, do any fat grafting to increase volume, or do any nipple reconstruction, those are all separately reportable procedures when doing the revision of reconstructed breast. Okay. There's also some additional instructions that are in there, which are that you don't want to code intermediate or complex skin repair with these. That kind of goes along with this, but just in that it includes some of this other stuff, but just a little heads up there. Okay, that does it for our breast section. I will do my best if there's questions after that, but like I said, there is a sea of new guidelines on that, so may have to get back to you on some of that. All right, we have 2 revised codes in the musculoskeletal section, and those codes have, again, gone to paragraphs. I guess it's good. Again, I kind of wish they would put these just as guidelines as opposed to putting it in the code description. But basically, these codes have been problems for a long, long time, right? We have 2 codes, a limited and an extensive debridement when doing arthroscopy of the shoulder. And what always happens with this is, okay, my definition of limited may not be the same as your definition of limited. So they have just really clarified that limited debridement is going to be 1 or 2 discrete structures, and extensive debridement is going to be 3 or more discrete structures. So let's look at and talk about what are the discrete structures. So they start with clarifying those, and there are a bunch of them. So separate is bone and cartilage. So we have humeral bone, humeral cartilage, glenoid bone, and glenoid cartilage. That's 4 discrete structures. We also have 2 discrete structures in the rotator cuff, the articular and the bursal. We have biceps tendon, glenoid labrum, and subacromial bursa, which all represent discrete structures that can be debrided in the shoulder. So I can already hear people groaning because you're going to have some physicians that are really good about documenting this and some physicians that just say extensive debridement done in the shoulder. And if they want to help you and get their own full reimbursement, they're going to have to be a little bit better about documenting exactly what structures they debrided. So that might be an opportunity for some physician education there. Okay, and as we said on the previous slide, limited is now going to be 1 or 2 structures. Extensive is going to be 3 or more of these structures debrided. All right, we also have some revised guidelines in the musculoskeletal section. I actually like this because this has been a source of contention for a while. So this is all arthroscopy codes again. Shoulder arthroscopy, elbow, hip, knee, ankle, and subtalar. In order to code a removal of a loose or foreign body, the guideline has been clarified now that you should only report that if the removal requires enlargement of the portal site or a separate incision to remove it out. And I love this because almost, you know, there's a lot of times that there is material in the joint that is debrided and taken out. Does that qualify as a loose or foreign body? It's not always clear. So now they've clarified it that in order to code this, there has to be some enlargement to the portal site or separate incision necessary. And for all of you musculoskeletal coders, that was nice and easy and phew, not much change for you this year. Jumping on to the respiratory section, we have 2 new codes. 30468 is the first one, and you can see the description there. It's repair of nasal valve collapse with subcutaneous or submucosal implant. It is designed to be a bilateral procedure. If it's done unilaterally, you're going to apply a 52 modifier. It does include repair of the nasal vestibular stenosis. And if you're doing this, repairing a stenosis without a graft or implant, that is an unlisted code at this particular time. Okay. It's a procedure that uses typically absorbable implant, usually not cartilage grafting, and it's actually sometimes done, mostly done in an office setting. So we also have 32408. Essentially replacing 32405. It's another one of those rules that they've been working on for years now to include the imaging guidance. So this code isn't any different than 32405 except for the key of we're adding imaging guidance. So it's actually very different. All right, our deleted code, our one and only deleted code is what we were just talking about. 32405 is gone. It's now been replaced with 32408 because of that imaging guidance. Easy peasy. All right, we've added, as we did with the integumentary section, we're adding lots of guidelines. And this gets a little bit complicated, so I would encourage you to just look at the guidelines. Basically, what they did was add a bunch of guidelines to let you know when you can code separate biopsies. So, core needle biopsy, which is what we're talking about here, it uses a needle, but it obtains a core of tissue versus fine needle aspiration actually just aspirates some cell cytology. So it's a different procedure. So of course, questions arise. When can I code both of them? When can I code more than one biopsy? All of that stuff. It's not actually on this slide, but I would tell you to be careful with all of this because the AMA guidelines are different than the CMS correct coding initiative. So depending on who you're billing, where you're billing, all of that kind of stuff. There are different guidelines for when you can do this. Okay. 32408 is going to be used once per lesion biopsy. So if you take 2, 3, 4, 18 biopsies of a single lesion, it's only going to be reported once. Imaging guidance gets a little trickier when you're talking about this, because remember now, imaging guidance is included in 32408. So imaging guidance could be reported if you're doing 2 core biopsies at different sites, and the second biopsy doesn't include imaging guidance. So essentially what you're doing there is reporting the imaging guidance for the biopsy that doesn't include it. You're not going to include it with the lung that does already include the imaging guidance. So you can code that. It's going to require a modifier to override the edit that's created. This is the one that's a little bit confusing to me and took me a couple of reads. If you're doing fine needle aspiration and core needle biopsy, it's the same lesion and it is the same imaging modality, you're going to actually apply modifier 52 to one of those codes. And that's basically to say, I'm reducing the service slightly because I didn't use imaging on both of these, or essentially it was the same imaging. That's a little confusing to me, but I guess it does make some sense in the minds of AMA. If you're doing FNA and core needle biopsy and you're doing it on the same lesion, but you had to use different imaging for whatever reason, then you're going to apply the modifier 59 because you need to get paid for both of those distinctly. And again, this is my warning that the NCCI manual does not necessarily agree with this. It's fun when CMS and the AMA don't agree and go their own ways on things. Makes it a bit of a challenge for the rest of us. All right, I am going to guess, I'm not going to spend a ton of time on the cardiovascular because for the most part, the changes that were made are usually these things are going to be done on an inpatient basis, but more and more stuff is being moved outpatient, so we are going to touch on it. All right, we have 92992 and 993 that are being deleted for these procedures. They were basically outdated methodology and kind of in the wrong section. They were in the cardiovascular medicine as opposed to being in the 3000. So the AMA is moving them up and updating our code descriptions and our methodologies for these procedures. So 33741 represents a transcatheter atrial septostomy that's done to create effective blood flow, usually in the setting of congenital heart defects, okay? It includes all the imaging guidance that's done, and it is any method. So they've listed out the ones that are used. Another paragraph description, a new code for the transcatheter intracardiac shunt creation. So this is where we place a stent for congenital cardiac anomalies to establish heart flow within the heart. Again, all imaging guidance is done. Note that this one includes left and right heart diagnostic cardiac catheterization. It includes angioplasty done in the zone. And you have one code for the initial shunt. I couldn't write all that out again. There's another code for each additional shunt location. And as a result of this, we've got some guidelines added, again, to kind of help you out there. So for the first code that we talked about there, the transcatheter septostomy, that one is a little bit different in that you can separately code diagnostic cardiac catheterization if there is no prior study or if the prior study was inadequate or the patient's condition has changed, that kind of thing. Kind of goes along with most of the other coding reporting guidelines there. Contrast injections may also be reported if cardiac angiography is done that's not related to the procedure. For the other two codes, the intracardiac shunt, that does include multiple stents placed in a single location. So you're not going to code that for every shunt that is reported. It's reported per location, not per stent. It does include the zone angioplasty and the diagnostic right and left heart cath. However, you can report the contrast injections that are not related to the procedure. Clear as mud, hopefully. Okay, we also added some codes for percutaneous ventricular assist device insertion or removal. Again, this is usually inpatient. If you're coding these CPT codes, you're probably on the physician side of things. But basically, we only had a code for ventricular assist device, and they basically just split this apart so that there's now specific codes for right heart and left heart, just because it can be done on both or one side or the other. As a result of that, we have a bunch of guidelines in there to help with that. If you reposition it without imaging guidance, you don't separately report. If you reposition during insertion, you don't separately report. If you reposition on the same day during a different operative session, you would report that. Replacement is reported using the insertion codes. We don't report removal. And replacement of the pump includes removal of the old pump. There's not a separate code for that. I wish they would just make the guidelines universal. Either we report removals or we don't. But unfortunately, it varies section to section as far as what's reported. So at least they're helping by adding guidelines for us. Right, we have some more guidelines added to the cardiac valves, just specifically as a result of what we were just talking about, those additions. So ventricular support required in conjunction with valve implantation can be separately reported, and they tell you how to do that. And then we have new guidelines in the grafting for CABG. Again, a lot of times, and hopefully an inpatient procedure. But just so you're aware, harvesting of the saphenous vein graft is included. And harvesting of the artery for graft is included unless an upper extremity artery is used. These revisions are a result of, again, those new codes. We added the right heart, and so what we had to do was take the existing codes and make sure that these were specifically for left heart. That's really the only change to these. And then for the repositioning code, they added right or left, just so that you know that that can be for either or. Halfway through, guys, don't anybody fall asleep on me yet. I'm going to give you back some time at this, I hope. The changes aren't as extensive this year. All right, digestive system is really simple. We deleted a code that was a huge code. Staging laparotomy. It included splenectomy, biopsies of liver lobes, lymph nodes, bone marrow biopsies, repositioning of the ovaries. Apparently they feel that this whole thing in its entirety is not often done anymore. So there's no specific replacement code. You would just have to go, depending on which procedures you actually do, those would be coded separately now. That's it for digestive. Nice and easy. The male genital system had a code added for ablation of malignant prostate tissue, and this is with the HIFU. I love all these acronyms. So right now, this is reported with a HCPCS code of C9747. There is kind of a major difference here. Maybe it's not. I'm not a doctor, and I'm definitely not a urologist, but it seemed a bit significant to me when looking through this, in that the CPT code adds the word malignant to it. So it didn't have to be a malignant indication when it was a HCPCS code. It does now. So just be aware of that. And it could be, I that it's only done for malignancy. Hopefully that's why. But this is the procedure that actually takes ultrasound waves and it focuses them, which generates heat and destroys prostate tissue. So there's a lot of different prostate procedures. Don't confuse them. All right, the female genital system has an add-on code that's been added for computer-aided mapping of the uterus during colposcopy. Note that this is always performed, at least according to the AMA, this is always performed in conjunction with colposcopy, which is why it says during colposcopy. But they decided that the work for this was not included in the colposcopy codes and that it warranted an add-on code to capture this procedure. Usually this is just an additional technique used to identify abnormal areas on the cervix in order to biopsy them. We have a couple of big overarching procedures that have been deleted, and this basically follows the same kind of guidance that our digestive system procedure did. This was huge, overarching. This one includes vaginectomy, removal of paravaginal tissue, removal of pelvic lymph nodes, and some more lymph node biopsy. So if you do that, depending on what you do, you're going to need to see separate sections of the CPT book to capture that correctly. And this is interesting to me, and I can't explain it. They deleted the vaginal hysterectomy for uterus greater than 250 grams. They kept intact this exact same code, but the one that says for uterus less than 250 grams. So I can't explain that. I'm not exactly sure why they would get rid of one and not the other. Maybe it was just an oversight. I find that hard to believe, but just be aware of that one. And that is it for the female genital section. And we are kind of home stretch with these, with the surgical section. We have some deleted codes in the nervous system. And you'll notice all of the stuff that was, or most of the stuff that was deleted this year has no direct replacements. They've just decided that these are obsolete procedures, that people don't do this really anymore. And so they went through the book and they're doing some cleanup to get rid of some of those things that either have no use or they feel are being used inappropriately. So craniectomy for implantation of neurostimulator electrodes, specifically in the cerebellar cortex, has been deleted. There is a code for if it's done via twist drill or burr holes, which is the more common one, not a direct replacement because this is for craniectomy, but that code is available. If twist drill or burr hole is not your methodology, you need to see the unlisted. Again, hopefully it's not being done. 62163, the neuroendoscopy with retrieval of foreign body, no direct replacement, use unlisted. And the laminectomy procedures with section of the dentate ligaments in the cervical area is also being deleted. So no direct replacements there, and you're going to go to the 64999. And then we had a lot of revisions, but they're not big deal revisions. They're just aligning these codes to make them children of our parent code of 64400. Every other code in that section was already a child of 64400, so we're just aligning there. Not a big deal. The auditory section has a couple of new codes for dilation of the eustachian tube via nasopharyngoscopy. And we just have a unilateral or bilateral, nice and easy, no modifiers really required. I like it. There were some notes added just to help you out a little bit that you're not to report an additional code for nasal endoscopy or for nasopharyngoscopy. Would imagine pretty much everybody already knows that, but it's nice when they kind of put it out there in writing for people that aren't quite as familiar with the coding guidelines. And last but not least, we have a deleted code, which is the revision of mastoidectomy. with apicectomy, and no direct replacement for that. So based on what you do, go to the revision mastoidectomy section. If you don't feel that one of those codes actually meets what you're doing, again, you'd have to go to the unlisted code. All right, that's it. We're going to talk about a few of the Category III codes that would possibly be coded by the HIM department. I am going to apologize here in advance. The HCPCS codes were very late this year. Everything was very late this year. Typically, I add HCPCS codes to this presentation. I just didn't have time to do that and get this all over and in. But we will be sure and publish all of those code changes out on VitalWare. We have a dashboard report that's going to tell you all about those. And we're always available for questions. Everybody knows, right? It has been a year with all of the changes coming, the public health emergency. Here's to 2021, and may it not be as disastrous as 2020. All right, so let's go to the Category III codes. We have another paragraph description here. So this is specifically for, right now there is one device that describes this. It's called a LimFlow, L-I-M-F-L-O-W. And it is basically for patients whose arteries can't be made patent for whatever reason. This is a way to shunt the arterial flow over to the vein to restore flow for those patients. And you notice they're helping us out here again in that this includes stent graft, it includes the closure, it includes the access, it includes the guidance, any catheterization, road mapping, anything necessary to complete the procedure is all inclusive in this particular code. We also have a couple of new codes for trabeculostomy ab interno using laser. One is without use of ophthalmic endoscope and one is with it. This is for the excimer laser trabeculostomy. Again, there's only one at this particular time. It's designed to create multiple channels that go through the trabecular meshwork of the eye that drains the eye. It uses a cold laser, and it's basically just to reduce the resistance and allow outflow of the aqueous humor, so to reduce pressure. Note that this also includes catheterization on the same eye, imaging, and supervision and interpretation necessary to complete the procedure. We also have 4 new codes for the injection of the allogenic cellular and tissue-based product into the intervertebral disc. And we're basically just sorted out based on the type of guidance used. So these 2 are for fluoroscopic. These 2 are for CT guidance. And this is usually used to treat low back pain that's of a discogenic origin. This is actually fairly new. This was just approved by the FDA in August 2019. So not a lot of you are going to be using this right now, but if it works out, I'm sure it will graduate up to Category 1 code. We also have 0632T, and this is specifically for treatment of pulmonary arterial hypertension. It's just amazing to me what they can do. So this is using ultrasound. It's used to ablate the nerves that actually supply the pulmonary arteries. It includes the right heart catheterization and the pulmonary artery angiography, all guidance used to complete the procedure. So it ablates some of the nerves, and that there's not as many nerves to be excited there, and it therefore helps to decrease pulmonary arterial hypertension. Several codes were deleted. you probably already know, but the Category 3 codes are designed to report new and emerging technologies. And so by design, they're not permanent codes. Typically, they're created, they're in use for a number of years until such time as the AMA determines that there's enough use and they promote them to Category 1, or that there's really no need and they delete them. So that happened with a lot of these. Very sad for them. None of them really got promoted. Apparently it was decided that there wasn't a need for these codes. So the anesthetic agent transforaminal epidural done with ultrasound guidance has just been deleted. So note that no direct replacement for these. If, however, you use fluoroscopic or CT guidance, there are already parent codes there. So apparently this just isn't done with ultrasound guidance, or not done enough to warrant a separate code. And we deleted the code for intraoperative use of Kinetic balance sensor for implant stability. The AMA is recommending an unlisted procedure code if that service is provided. Although I do kind of wonder what that would do from a payer perspective if they were to see, you know, a knee replacement and then a 27599 on the procedure could slow down your whole claim and payment there. So just be aware of that one as well. And that is it for our CPT updates.
All right, great. We're going to take some live Q&A. We have a number of questions already. If you do have a question, please use the Q&A panel. We probably won't get to all of them live, but we will make sure to try to get all the answers posted within a week or so for sure, so that you have those answers. Just a reminder to everybody, we always get a lot of questions around the deck presentation. Yes, it will be available on demand following this, so you'll be able to rewatch the webinar, download the PowerPoint as a PDF, as well as we'll be emailing you the information on the CEUs for AAPC and AHIMA following the webinar as well. So with that said, again, I said this yesterday, but I can't believe you can pronounce all these words. So get ready to laugh, because you're going to hear me try to pronounce some of these words, and it's not going to be good. So here we go. Should we currently code the administration of monoclonal antibody bamlanivimab when they receive the antiviral med? Sorry about that already, but there you go.
Yeah, so that's referencing the new outpatient therapy that has been approved under the emergency use authorization for outpatient treatment. And they were asking about the drug, correct? Not the administration? Do you...
Should we currently code the administration?
Oh, the administration.
When they receive this antiviral med?
Yes, they did release both a new code for the drug, Q code, I believe, and a code for the administration, a new M code. Now, at the current time, so expect things to change, as with everything here, but at the current time, that drug is being provided to select hospitals free of charge. And so coding for the drug itself, CMS actually has instructed that you should not code for the drug at this current time as long as it's provided to you free of charge. And they are implementing some overrides, I guess, for lack of a better term, so that claims processing edits should allow your claim to pass with just an administration code and not the drug. You can report, under current rules, you could report the drug with a very token charge, less than $1 charge. But yes, you will code the administration. Whether or not you code the drug will depend on whether you're still continuing to get it free of charge and how your billing system is set up. That complicated enough?
It's for me. I have a feeling people are going to plant questions now just to hear me pronounce words, but I probably shouldn't give people that idea. Our next question is 19370 in addition to 11970 or in place of?
Okay, wait a minute. Do that again. 19370.
19370.
Uh-huh.
11970.
11970. I'm madly, and I'm not going to belabor this too much. We may just say that some of this is going to have to be answered in.
Yeah, that's a follow-up question. That's fine.
In our follow-up question. Yeah, so that's revision of peri-implant capsule and replacement of tissue expander. Gotcha. Okay, yes. And we did go through that is one that you could add the 19370, but it has to be a significant revision. If it's just minor revision to the breast capsule, then you wouldn't add that. And that's the one that's a little subject to interpretation as to what is minimal revision and what is significant revision.
But it is in addition to, not in place of, it sounds like.
Yes, yeah.
Okay.
Yeah, basically, and yeah.
All right, next question is 32408. Now includes imaging guidance. So how should a hospital radiology department report the radiology part when the OR part is reporting 32408?
Yeah, and that's been a challenge for radiology departments over the past several years as more and more of these codes get combined. What you absolutely do not want to do, that unfortunately I've seen way more hospitals do, is basically just chop off the radiology component and not ever increase the charge over to the surgical component, which effectively tells Medicare, this procedure just got a lot cheaper for us, which we all know is almost impossible to have happen. So what a lot of hospitals do in order to capture that time, there's a couple of options, right? You could make a statistical only charge for your radiology department that's not going to generate an additional charge, but it will let everybody know that there is radiology time involved in that and what there exactly is. Or you can, if your billing system will allow you, you could report charges on the radiology, but it's going to have to roll up into the 32408, and that's sometimes really difficult. So probably statistical is the best and easiest way to do that.
Okay, great. We have a number of questions on 32408, so I'll ask one more there, but then we'll move on to other topics, I think, and we'll have those follow-ups. For CPT 32408, if you have more than one lesion in different lobes or lung and are doing all core biopsies, how many can you charge?
Well, I'll need to research the MUE on that, but the rules say that you can charge it once per separate lesion. So it would be, and I'm sure there's an MUE value on that, so we'll add that to the FAQ document, but it is once per separate lesion.
All right, what about performing an FNA and a 4-step biopsy of the lung? Can we code both using the modifier from the slide? I'm not sure it's slide, but.
Yeah, no, and that's the tricky one because the AMA says absolutely yes. They say that is a separate procedure to obtain different samples for different reasons. Medicare, however, says no. They say if you are doing a core needle biopsy and an FNA on the exact same lesion, that you would only report the core biopsy service. They consider it a more extensive procedure. So that's one where you have to be a little bit careful with it.
All right, next one. Breast augmentation with fat removed by liposuction. Is the harvest of the fat inclusive to the procedure?
Yeah, I am 99% sure that it is. But again, I will, if that's not correct, I will we'll make sure that we get that updated in the FAQs.
If Jen's 99% sure, I feel pretty comfortable about that. So, next question is, what about the HCPCS C9745 surgical ballooning with the new codes 69705 and 69706.
Yeah, that one's going to have to go back. I can't. Okay. Yeah, I'm not going to be able to answer that one right now. Sorry.
Someone just said, did I miss the deletion of 99201?
Well, thank you. I need to go through that spiel again. Yes, good point. No, you did not miss it per se. We have that in tomorrow's presentation in the very capable hands of the wonderful Ardith Campbell. And the reason it's not included on either one of my presentations is because the E&M codes, I realize that hospitals code 99201 to 99215 to report outpatient clinic visits and other services. However, they do not use the descriptions in the book. So those descriptions are changing. There's a lot changing with E&M guidelines. And Dusty, maybe help me. When is the 12th? Maybe is the webinar specific to E&M? Something like that.
Yeah, we'll make sure to post that. But
yeah, we'll make sure to post that. But those guidelines, those changes in medical decision-making time, the other things that are happening, don't pertain to facility coding, right? If you're in a facility and you assign one of those codes, you have to create your own internal guidelines that correspond to those levels, and there's no reason for them to relate to the descriptions that are in the book, because that is for physician coding. So that is why I have not included anything to do with the E&M changes in my presentation.
Yep, and the E&M webinar is the 17th of December.
Oh yeah, 12th would be a Saturday. That would be no good.
Got some diehards, but I don't know that much. All right, just a couple more questions, and we're going to be out of time, unfortunately. Can we code 45335 and 45350 together?
45335 and 45. That might have to be when I take back too. I'm furiously trying to look up.
I should know better.
Yeah, 45335, and I'm sorry, what was the other one?
350, 45350.
Yeah, we're definitely going to make sure that we take a look at that. I believe the answer is yes, but I don't have the CCI edits in front of me to know for sure whether that's included or not.
Okay, someone's asking they said the sound went out on the note on 32405 in 408. Do you have a really brief summary on that?
Yeah, basically just that it's kind of sort of the same code, only we're now including the imaging guidance. We don't have a ton of codes left that don't have the imaging guidance, but they've basically been working to package that into all the procedures for a while now.
All right, this is going to have to be the last question, unfortunately. If image guidance is not performed with 32408, is it appropriate to report a 32408 with a 52 modifier? Or is another CPT, such as unlisted, more appropriate?
Oh, that is an excellent question, and I will do some research, but I right now off the top of my head would favor the unlisted and hope that that's not done real often, because if I remember right, when the AMA looked at this, it was like 99% of the time that imaging guidance was used with this. You don't really want to be poking around in the lung without knowing where you're going.
That's good life advice right there.
Yeah. Yes, it is.
Okay, that's great. There are some great questions still. Again, we'll make sure we follow up with an FAQ doc on all these things. There are a number of changes. People are asking about the future webinars. So if you go to vitalware.com/webinars, that's where all of our future and past webinars are. So you can watch old ones, you can sign up for new ones. If you can't find that page, we have live chat on every page. Talk to that person and we'll make sure we get to the right spot. CEUs will email the information out following this webinar later today. along with a link to this specific webinar where you can download the presentation and rewatch if you want to. And once we have the FAQ doc, that's where we'll post that as well. And so I'd recommend bookmarking our webinar page. We continue to put out more and more of these to help you guys out. Other than that, did I miss anything, Jen? We good?
I don't think so. I think we're good.
All right, hopefully we'll see most of you tomorrow, and we're going through the physician side of things. So see you all then. Thanks for coming.
Thank you.